Hey there, it's Dr. Matt. I'm a first year ECC or Emergency Critical Care resident at the North Carolina State University. They are not affiliated nor do they endorse my channel. I'm a veterinarian and welcome back. My video last week was just kind of like an introduction to the channel, what ECC is, and it's kind of my first week in review. Interestingly enough, I made a video after my first day, and for whatever reason, it malfunctioned. So instead of trying to make that multiple times, I figured might as well wait until after the first week. So what was my first week? So I was on triage, or in other words, day emergency, and it was great. Saw a lot of cases, saw a lot of complicated cases, including heat stroke, severe hypernatremia, a brainstem tumor, an acute disc in a neck, so on and so forth. It's really nice to be back teaching students and now teaching interns. I love it. It's so much fun. My mentors are fantastic. I'm getting really great mentoring along the way. Primary case management, all of that. It's really exciting to wake up and be excited to go to work despite traffic. So let's see what else happened this week. So I had a meeting every morning at either 8 or 8:30. Monday and Tuesday were ECC kind of rounds. Tuesday was a book chapter review on microcirculation by boron. Here it is here, 35 pages. If you ever need to read something to go to sleep, that is definitely one of them. And then, of course, my mentor, who is ridiculously intelligent, distilled it down pretty easily when I was getting ready to bash my head against a wall, reading it on my own. So that's nice. I'll include kind of the name and where you can find it down in the bottom if you would like to go to sleep after reading it. Let's see. On Wednesday, we had medicine rounds, which kind of this whole week was just introduction of the first year residents and the interns and current residents as well. And then Wednesday was cardiology, so we did basics and introduction to electrocardiograms or ECGs, which we're going to build off how to read arrhythmias and interpretation and whatnot from there. This upcoming week, so Monday through Thursday, I think it is, I'm going to be on the intensive care unit or ICU during the day, and I'm so excited. Looks like last week it kind of exploded in there. There was a mechanical ventilation case. There was a dog that needed a tracheostomy tube or essentially a surgical airway, and a lot of other really cool stuff. So we'll see how it goes being in a critical care, high stress, high case volume, ridiculous intensity kind of environment. But I'm really excited. I know I'm going to be overwhelmed, but it's probably natural. That's what I tell myself. Okay, so let's see. So I had a really cool severe case of heat stroke this week, and I've never seen a case of heat stroke that was this advanced and this severe ever. I've seen a few cases before, and I've heard about some crazy ones, but this really made me want to go through kind of the pathophysiology, kind of more in detail, book chapters, research articles, stuff like that, to not only learn more, but I'm trying maybe once a week on this channel, whether it's in my weekly residency update videos or on separate video, to like include something to teach about, because it also helps me learn as well. Especially, I know boards are 3 years away, but I'm sure that'll go by pretty quickly. So heat stroke, you don't actually have a stroke. Let me put it that way. Essentially, there's kind of a continuum of what's called heat-associated illnesses. So there's heat cramp, which is what happens when sodium and chloride kind of leads to muscle spasming, secondary to prolonged exposure to the heat. But the body temperature usually remains within normal limits, which for dogs and cats can be anywhere between 99.5 degrees Fahrenheit to 102.5 with a little bit of a tiny bit of wiggle room. The next thing, which I think is probably more common in people, is like heat exhaustion or heat prostration, in which you're more likely to see systemic signs such as tiredness, GI upset via vomiting, diarrhea, diarrhea, and muscle tremors. And your body temperature can be normal or be a little bit elevated. So in a dog or a cat, that could be 102.6 to maybe 103.0 degrees Fahrenheit. And then what we're really talking about today is heat stroke. So this is a non-pyrogenic increase in body temperature, not due to a change in the hypothalamic regulatory set point, and causing systemic inflammatory responses, which lead to activation and damage amongst many to all organs, leading to further dysfunction. And the hallmarks are usually CNS or central nervous system disturbances. So what more do we want to know? So there's two types of heat stroke. One is exertional, so it's exactly what it sounds like, is you see these signs of too much heat in the body not being able to handle it when there's too much or strenuous exercise going on. So think of it as any dog that's outside on a warm day and is running around like crazy, chasing after that ball. You've thrown it 35 times, and they just can't get rid of that heat compared to how much they're kind of taking in, for lack of better words. The other type is non-exertional, so it's essentially not associated with exercise, but it's due to exposure to increased temperature outside, combined with a reduced or absent ability to cool, which we'll talk about again shortly. Kind of a classic example are dogs being left in vehicles on really hot days with no air conditioning, or they're left outside with no access to water and or no shade. So we predominantly see this in dogs, especially during the hotter months, such as June to August, depending on kind of where you're at in the United States or where you're at in the world. Again, doesn't necessarily have to be associated with exercise. Factors that can kind of reduce the ability for the respiratory system to not being able to evaporatively cool. So when dogs pant, that's the major mechanism for them to kind of dump out some heat from their body. Could include humid climates, so really hot, kind of like moist, everyone's favorite word, feeling climates, like the further south that you go, especially along the eastern coast. Close confinement and poor ventilation. Upper airway obstruction, so brachycephalic dogs such as pugs, boxers and such. Laryngeal paralysis or collapse, upper airway masses, and then collapsing tracheas, such as like Shih Tzus or anything kind of small like that. One study by Bruchim, I'm sorry, I don't know how to say their last name, said about 78% of these cases occur from June, July, or August. It's less frequent later on in the summer, usually due to acclimatization, butchered that word, to these pets to the outside. This is really uncommon to rare in cats, so the literature is pretty sparse to non-existent. So, predisposing factors that can increase the risk or the prevalence of heat stroke include obesity, so hypovolemia or poor circulating volume, heart disease, poor cardiac output, and then animals that have extremely thick hair coats, whether that's just naturally by design for the dog breed or they haven't been groomed and there's an excessive buildup of coat. Lack of acclimating to the heat. So in dogs, it can take up to 60 days or 2 months for them to acclimate to changes in heat and humidity. But we typically see kind of like a partial acclimation within 20 days or so. Upper airway obstructions and the non-working dogs. And what I mean by that are military working dogs and racing greyhounds or other kind of racing breeds are less susceptible to heat stroke because of these pets or these working animals typically are more knowledgeable to kind of things such as heat stroke than just the lay pet owner. So the pathophysiology, so kind of makes sense in that this is kind of a fine balance between heat load or kind of the environmental heat and cellular metabolism and heat dissipating mechanisms. It's kind of managed by the hypothalamus or some part. So there's 4 mechanisms of heat dissipation. So there's convection. So that's the movement of air over the body to disperse heat, such as like wind or air from a fan. So if you're standing outside and you're running around and you feel that breeze come over you, that's an example of convection. The second heat dissipating method is conduction. So that's transfer of heat from one object or body to another. So in other words, if you were to go step on concrete that's been in the shade all day and it feels pretty cool, the reason for that is that the body heat from you or the animal is now being transferred to the cooler object. The next one's radiation, so that's body heat dissipating into the environment. So in other words, if you go outside or your dog goes outside and it's 0 degrees out in the winter and it feels pretty cold, well, that's your body heat directly leaving your body and into the environment. This is usually seen to be less effective when the ambient temperature reaches body temperature or higher. In other words, the summer, when it's above 100 degrees outside. And the last one's evaporation. So we typically, for dogs, this is the main method that they get rid of heat is by panting. And this is more effective when the ambient temperature outside reaches about 90 degrees Fahrenheit, but it's less effective when there's a higher humidity. So between the 4 of those, convection and radiation are kind of the major methods in which skin in small animals kind of maintains heat loss. And the reason how this happens is that the vessels in the skin vasodilate secondary to the sympathetic nervous system to improve cutaneous circulation and kind of like dumping out that heat from the body into the environment. So initially in heat stroke, it's acute phase response leading to inflammation and kind of other secondary changes. So the acute phase response is kind of mediated or has a lot of things underneath of it in order to protect the body tissues from damage and help promote repair to a certain degree, right? So there's negative acute phase proteins, which a lot of people think of albumin or the major proteins circulating in the blood that, one, helps with colloidal osmotic pressure, but also the transport of drugs and hormones. Negative acute phase proteins include transcortin, transferrin, and retinol binding protein. On the other hand, we have the positive acute phase proteins, and that can include heat shock proteins, C-reactive protein, serum amyloid A, haptoglobin, and fibrinogen, amongst a variety of other ones. So the interesting one, or the important one that I want to touch upon, are the heat shock proteins. And so what these do down on a cellular and tissue level is try to protect proteins from denaturation or kind of falling apart secondary to excessive heat. And prevent the disaggregation of these denatured proteins, helps refold denatured proteins, and then protects against endotoxin leakage across the intestines, since that's where a lot of bacteria that contain endotoxin reside. And then it's also supposed to reduce cerebral ischemia. It also helps regulate the baroreceptor response during heat stress to prevent hypotension, whether that's relative or absolute. Going back to C-reactive proteins, so this activates the complement system to promote cytosis or either cytokine production and chemotaxis, or chemical signals that help kind of activate other things or attract other cells or molecules to a certain site. Serum amyloid A, which I feel like we commonly measure more so in horses or animals that have amyloidosis. What this molecule does is it induces chemotaxins of several leukocytes and then inhibits inflammation to a degree. Other things, like I said, are haptoglobin and fibrinogen. So after we start this acute phase response, we start to see production and release of interleukins 1 and 6, which are pro-inflammatory molecular molecules, particularly from the muscles, and then they get absorbed and go into the systemic circulation. In addition to that, absorption of endotoxin from the GI tract due to increased permeability of the gut increases kind of mucosal permeability and tissue permeability to other molecules. So what we really get worried about with heat stroke are changes in coagulation, whether that be hypercoagulability or hypo, in other words, throwing more clots. And it also leads to inhibition of fibrinolysis. So basically what we don't see with the naked eye, or maybe not even clinically, are like microthrombroses, leading to progressive tissue injury, and then even worse, direct endothelial cell damage, leading to multi-organ damage and dysfunction. So as a budding critical care resident, something that I really like is called SIRS and MODS, so Systemic Inflammatory Response Syndrome and Multiple Organ Dysfunction Syndrome. Essentially what SIRS is the body trying to react and protect the body, but it goes a little too crazy and can lead to changes in vital signs and other things, and can eventually lead to MODS, which is 2 or more body systems that are affected and begin to fail, whether that be the kidneys, the central nervous system, the liver, or all the above, and then some. So effects by body system. So for the central nervous system, it is increased risk for excitotoxicity leading to neuronal death, and therefore cerebral edema, hemorrhage, and necrosis. changes in coagulation, so it's also another issue with direct cytotoxicity and endothelial cell death. And this releases thromboplastin and factor 12, which activates the coagulation cascade, and eventually, if gone unchecked, can lead to disseminated intravascular coagulation, or DIC, which is a syndrome. It is not a diagnosis, and it is never a primary process. It's always due to something else. And how this is diagnosed typically is by thrombocytopenia, or low platelets, and prolonged clotting times, such as PT or PTT. And it's kind of taught in school how there's the hyperdynamic phase followed by the hypodynamic phase, and we see excessive clotting and then the inability to clot, and it's harder to see the former rather than the latter. However, I think a lot of students, interns, and whoever else fail to recognize or remember that both of these processes are happening at the same time, okay? And DIC, unfortunately, the first time I've ever heard of it, you might hear it as death in cage or death is coming. Cardiovascularly, so we usually see an increased cardiac output to help with kind of keeping the body hemodynamically stable, with central vasoconstriction and peripheral vasodilation, again, to help kind of offload some of this heat, to increase the surface area of the cutaneous capillaries to help offload that heat. However, if going on too long, some sequelae could include blood pooling in the venous systems, central vasodilation, leading to an absolute or relative hypovolemia, hypotension, and shock. Other things that can occur secondarily are electrolyte derangements, metabolic acidosis, and genesis of microthrombi, which we have kind of already talked about earlier. And then arrhythmias can occur, especially ventricular arrhythmias, when these clots or ischemic events do happen in the myocardium. In the lungs, so it's kind of similar as before, so there's direct injury to the vascular endothelial cells, but in the lungs this time, and this can lead to increased permeability, so pulmonary edema, increased vascular resistance in the lungs, and then acute respiratory distress syndrome, also known as ARDS. In the GI tract, again, direct cytotoxicity, and then with prolonged hypotension, hypovolemia, generation of clots, and perfusion issues, that leads to ischemia and increased permeability of the GI mucosa, which then can lead to bacterial translocation into the systemic circulation and cause things such as bacteremia and even sepsis. Other things that can occur as well would be the generation of reactive oxygen and nitrogen species, or ROS and RNS, which kind of further propagate this issue. And this can lead to, again, sepsis, cardiac dysfunction, and death. Last but not least, the best organ is that the kidneys can receive direct thermal injury with protein denaturation, and then renal tubular necrosis. And then indirect injury, similar to others, via vasoconstriction, so decreased blood flow or perfusion, dehydration, and then myoglobinuria can cause myoglobinuric nephrosis. And usually the myoglobin comes from kind of widespread rhabdomyolysis, or breakdown of a lot of muscles. So in terms of diagnosis, it's not always a straightforward shot, and we'll talk about that shortly, but usually it's like compatible history and exposure. So we know we're having a heat wave. The other day in North Carolina, it was like 95 degrees outside, pretty humid, and it was a young dog that was going crazy outside, as they always did, and it was just too much. Physical exam findings can include altered mentation, whether that be to slightly off, confusion, stupor, and coma, and pupil size such as miosis or small pupil, or mydriasis, which is an enlarged pupil. Regardless, they can be normal, but they should be able to keep their pupillary light reflexes, or their PLRs, intact on exam. Other things we can see would be like cortical blindness, ataxia if they are still walking, head tremors or bobbing, and kind of the such, even seizures. Luckily, according to one of the articles I was reading, is that the dog brain's much more resistant to thermal injury than humans, so these heat stroke dogs don't necessarily have to present with neurologic dysfunction. I think that's more common in people. The body temperature can be normal or altered. One, it depends on the state of perfusion, but also if the owner or the referring veterinarian, whoever, has kind of already initiated treatment. You can see sinus tachycardia and increased peripheral pulse rate. Weak pulses, hyperemic or red mucous membranes, which usually are secondary to vasodilation with a capillary refill time of less than 1. And just a quick soapbox, I see a lot of people write that on a physical exam, oh, CRT was normal less than 2 seconds. Well, in a way, sure, 2 seconds is normal. 1.5 might be normal, but anything less than 1 second is not normal. Vasodilation should not normally be happening. Not like that. Tachypnea or increased breathing rate, and then there's effort, and they can have louder, noisy breathing and crackles. And the loud, noisy breathing can be if it's a brachycephalic dog or if it's a dog that has a lot of edema secondary to excessive or prolonged panting without intervention. Common things, since the GI tract is usually one of the first things hit pretty severely, can include diarrhea, hematemesis, hematochezia, melena, anything like that. And then something that hopefully you'll notice pretty quickly is petechiation or ecchymosis, which in lay terms would be small pinpoint bleeding or large bruises. I'm going to go pathologically, so blood work, big fancy word, right? So kind of step by step, and everything that I list, you don't have to see all this at once. You could see all of it. You could see a few of them. You could see a combination. It's just throughout the research that I did. On complete blood counts, you can see hemoconcentration or relative erythrocytosis with an increased hemoglobin concentration. Interestingly enough, you can see an increase in nucleated red blood cells due to direct thermal damage to the bone marrow plus or minus splenic contraction. And a study by Bruchim, again, probably obliterating that name, reported that about 68% of dogs in a retrospective study of 54 cases from 1999 to 2004 had increased mortality, and especially if they had a nucleated red blood cell count greater than or equal to 18 per 100 leukocytes. It was also determined to be a sensitive and specific marker of death in dogs with heat stroke and used as a prognostic indicator or a negative prognostic indicator by Aroch, which was published in JVAM in 2009. Other things you can see are schistocytes or fragmenting of red blood cells, and then thrombocytopenia secondary to platelet consumption and aggregation from direct endothelial injury as well as disordered coagulation. So biochemically, or on your chemistry panel, you can see hypoglycemia or low blood sugar, and this can be due to a variety of reasons, like an increase in demand for ATP, plus or minus decreased hepatic production or decreased hepatic gluconeogenesis if the liver is taken that big of a hit secondary to direct injury or ischemia. Other things could be evidence of hepatic enzyme elevation, so ALT, ALP, hyperbilirubinemia, and low cholesterol in certain cases or severe cases. An increase in AST and CK are probably pretty common, especially if you have increased evidence for rhabdomyolysis leading to kidney injury or failure. And in order to see that grossly is if you take some urine, their urine is usually going to be brown. Other things would be like a hypercreatinemia, or again, the best organ in the body, so a high creatinine, and this can be due to pre-renal from dehydration and or hypovolemia, but also due to intrinsic renal injury. And you're probably going to see an increased BUN, especially if you do have bleeding within the GI tract. You can see alterations in total protein, so you can see a pan-hyperproteinemia due to dehydration or shock. You can see a pan-hypoproteinemia if you have a protein-losing enteropathy secondary to sloughing the gut, or you can have a selective hypoalbuminemia and a selective hyperglobulinemia secondary to systemic inflammation. Hypernatremia is definitely possible with, again, secondary to dehydration, but something that was interesting that I did not think about is dogs that are excessively panting can have an excessive free water loss secondarily, leading to hypernatremia. And then last but not least, at least for like a chemistry profile or a venous blood gas, is you get type A hyperlactatemia, secondary to decreased perfusion. Or in your coagulation profile, so I'm lucky here at NC State where it's not just your prothrombin time and your activated thromboplastin time. We also have D-dimers on there and fibrinogen, which is super exciting to give us a little bit more of a well-rounded idea of the coagulation system. So we usually if we're going to see changes, we're going to see elevations or prolonged times in PT and PTT. Kind of the general rule of thumb is it depends on papers, but I use if it's above 25% of the upper reference interval, then I count that as clinically significant. And then dysfibrinogenemia, so it can be high fibrinogen secondary to inflammation or low due to excessive use. And then increased D-dimers secondary to fibrinogen or fibrin split products. For urinalysis, I would highly not suggest that you do a cystocentesis. I would probably recommend either it's free catch or you do catheterization, which we'll come back to again in a little bit later. The urine-specific gravity can be kind of all over the place. You would suspect it to be high secondary to dehydration. However, if it is isoscenuric or hyposcenuric, then we do get a little bit more worried about intrinsic renal injury if they don't have a pre-existing kidney disease. Other things that kind of give you evidence for acute kidney injury would like be proteinuria, hemoglobinuria, myoglobinuria, and renal casts, among other things. Last but not least, unfortunately, if you do get to the point of a necropsy, or essentially it's the same thing as an autopsy, some things you can find would be like hepatomegaly, splenomegaly, or hepatosplenomegaly, bleeding in just about any organ, necrosis and edema of the cerebrum, and then glomerular congestion and renal tubular degeneration and necrosis. So, after all that yammering, now what, right? You've identified it, what do you do now? So, treatment. And the most important part, and I cannot stress this enough, is active cooling, okay? And the biggest thing that I have to share with people is do not use ice. Do not use cold water. You want to use cool or tepid water. The reason why you do not want to use ice, don't do it, would be that when you use ice and you put it on the body, you would think, okay, the coldness is going into the warm body. Sure. However, what happens is locally, that really, really ice cold water or that ice causes vasoconstriction and actually decreases the ability to offload heat. Other things that people might think is, okay, let's get some cold water into the body via an enema or a gastric lavage or kind of like pumping the stomach. Do not do that. You are more likely to cause damage and injury to the GI tract and further worsen prognosis and mortality. So do not do it. Other things that can be done that I've seen people do, but I would not do because there is no scientific-based evidence for this, is applying alcohol to paw pads or other parts of the body. The reason why is we know from like Molotov cocktails that alcohol is very flammable, right? Well, if this patient goes into ventricular tachycardia or ventricular fibrillation and you need to defibrillate them, you're going to catch them on fire. So not only are they figuratively burning, they're literally burning, okay? So don't do that. So kind of the best methods you can do is if they are normovolemic and you're catching this early, is you can take cool or tepid water and kind of run it over them continuously. Use a fan blowing on the dog to help combine evaporative and convective cooling measures like we talked about, which seems like forever ago. You want to stop these active cooling methods when they get to about 103.5 degrees Fahrenheit or 104.0 degrees Fahrenheit to avoid rebound hypothermia. If they are hypovolemic, you can go ahead and give them, you should always place an IV catheter in these guys, no matter what, even if they seem to be okay at first, because things can change rapidly. You can give a bolus of IV fluids. Ideally, it would be a balanced isotonic crystalloid, such as lactated Ringer solution, Plasmolite A, or Normosol R. I would not use physiologic saline or 0.9% NaCl because that's a high load of sodium and chloride, which can predispose to renal injury secondary to vasoconstriction from hyperchloremic metabolic acidosis, which is something I talk about a lot with students, but something is better than nothing. And sure, the circulating blood volume of dogs is thought to be 90 mils per kilo and cats 60 mils per kilo. But my understanding is that study where we kind of got those values were for animals that were under general anesthesia a long time ago, and it's an estimate. So just because that's their proposed circulating volume, that doesn't mean give them that much fluids, right? I like to be able to give a little, and you can always add more, but you can't give a lot and take some away. That's not how that works. So what I typically do for cats is I'll do 5 to 10 mils per kilo IV over 10 minutes, and then for dogs I'll do 10 to 20 mils per kilo over 10 minutes. Anything more than 15 minutes is an infusion, not a bolus. See, something interesting that I wanted to share that I found that I was not aware of is that you want to try and control shivering in the patient, right? So again, avoid using ice. However, it's thought that shivering kind of contributes to hyperthermia, and it definitely contributes to hypoglycemia. But there is a study by Haddad back in 2004 published in Sports Medicine saying that this was not found that shivering kind of significantly contributed to hyperthermia because it was relatively minor in the amount of cooling that was achieved during emergency treatment and resuscitation. Another interesting thing that's been shown to help is massaging the muscles to improve circulation, which now that I think about it does make sense. So also you need to evaluate the airway, especially if they're brachycephalic or they have loud or raspy noises. You want to check that airway, and if it's clear and there's no issues there, flow by oxygen's never really wrong, at least in the short term, which is also a little bit cooling. If you have any doubt, when in doubt, intubate it. Okay, intubate them. And I would prefer that over an emergency tracheostomy because if you have coagulation problems, the tracheostomy, you could bleed down into the lungs. But again, you do what you think is necessary for these animals, okay? And then once these guys are settled, you replace their fluids as needed over however long you think based on their risk. But in terms of maintenance fluids, and you'll hear me say this all the time, is that for maintenance needs, which is estimated to be 40 to 60 mils per kilo per day in adults, not young or geriatric animals, use a maintenance fluid. Use a maintenance fluid. A replacement fluid is not a maintenance fluid. So examples would be half-strength saline or 0.45% NaCl, plasma light B, or Normasol M, M for maintenance. And if they are hypoglycemic, you can go ahead and give them a small bolus of dextrose as needed, so 0.25 to 0.5 grams per kilo diluted however you want to dilute it, a 50% dextrose, and kind of give it over X amount of time, and supplement that in the fluids as needed. So fortunately, half-strength saline does come already in a bag, a commercial bag of 0.45% saline with 2.5% dextrose, so I like to use that a lot if needed. And then it's one of the few cases that empiric antimicrobial therapy is appropriate, especially if they're severely affected. So you want to use a broad spectrum antibiotic or antimicrobial. And there's a variety of options. So you could use something like ampicillin or ampicillin plus sulbactam in the form of Unicin. There's enrofloxacin / Baytril, and then there's metronidazole. And I think, to me, there's kind of pros and cons for metronidazole in that the pros are a lot of what's coming from the GI tract are anaerobes, right? So metronidazole has a great spectrum for that. But as you might remember, that metronidazole can cause neurotoxicity, and it can be at any dose, at any time, at any frequency, no matter what. So if you have a dog that's already neurologically dysfunctional, I might avoid using that because I want to make sure that I'm not the one contributing to the patient getting worse, and it's natural progression of their disease. If that makes sense. So for GI support, I think it'd be really nice, especially when they're sloughing their gut, to use antiemetics and anti-nauseas such as meropenem, ondansetron, or metoclopramide, or any combination of those, whichever one's your favorite. And then GI protectants. So the best group would be the proton pump inhibitors or the PPIs such as pantoprazole, which is injectable, or omeprazole or esomeprazole, which are orals if they're taking that for you or they have a feeding tube. Sure, you could use H2 histamine receptor antagonists such as famotidine, ranitidine, or cimetidine, but I really stress that you guys, I'll include it down below in the description, hopefully I'll remember, that it's not really that effective, and research has proven on intragastric pH doesn't actually increase or become a smidge more basic unless you do a 1 milligram per kilogram IV loading dose followed by an 8 mg per kg per day constant rate infusion. Okay, and then for CNS support, you can use mannitol or hypertonic saline, and there's a whole debate about which one's better than the other, which one's more appropriate, and I'll leave that up for you guys if you're interested to look into. I could talk about that for about an hour. Other things would be like cardiac support. So if they are having ventricular arrhythmias such as ventricular tachycardia and so on and so forth, or continued VPCs, you can consider that like a 2 mg per kg IV dose over a couple minutes. And then dopamine for vasopressor support. So nursing care, again, super important. Would it include reduction or maintenance, or reduction of intracranial pressure, so keeping the head between 15 and 30 degrees elevated from the horizontal, and please refrain from compression of the jugular veins or jugular venipuncture. Again, if a central line is required, do what you got to do. Maintenance of a urinary catheter. So remember that for dogs and cats, physiologically, their urine output is 1 to 2 mils per kilo per hour. And while they're on fluids, they should at least be at 2 mils per kilo per hour. If they're at about 1, that makes me a little bit anxious that they have intrinsic AKI or are about to be oligoanuria. So nutritional support is important. It's forgotten about a lot in a lot of diseases, not just heat stroke. So if and when you think it's appropriate and your patient's still not eating, placing like a nasoesophageal or nasogastric tube so you can feed the gut. The best way for the gut to recover is by feeding it, okay? And that helps with replacement of electrolytes and albumin, which means that you can give less fluids IV once you get to the maintenance phase. And then last but not least, the coolest thing is hemodialysis in those oligoanuric patients. So for monitoring, I highly recommend that you do a physical exam at least twice a day, hopefully more than that. I'm not saying every hour, but hopefully every few hours as dictated by your caseload and your staff availability. Frequent TPRs, respiratory effort, and modified Glasgow coma scoring, especially if they're already obtunded or mentally inappropriate. Remember that a score of 8 or less is associated with a worse prognosis in general and trending downwards, so then you can hopefully intervene before you get to that. Monitoring blood pressure, so I think indirect via Doppler is appropriate, not a fan of oscillometric, and then direct via an arterial BP if they have a coagulopathy. I'm really not trying to get into an artery. And so keeping that mean arterial blood pressure at about 80 or slightly more millimeters of mercury looks pretty good. And then ECG monitoring or telemetry. Other things could include like daily or twice daily PCVs, total proteins, glucose, electrolytes, lactate, acid base, and coags, based on your index of suspicion and how the patient's doing and what finances look like. And then again, urine output. So for prognosis, and I definitely have to look at my notes for this one, is that it's most dependent on the length of time of hyperthermia and time to admission, especially the highest body temperature experienced, at least known. So at temperatures of 109.4 degrees Fahrenheit, there's going to be marked organ damage and increased mortality. And then when they're above 120.2 degrees Fahrenheit for more than 5 minutes, widespread cellular necrosis and destruction happens. The prognosis is about 50%, and that's secondary, or 50%, which is reported by Bruchim, which I'll kind of include them in below. And then negative prognostic indicators, so there's a lot, but delayed time of admission to the hospital of more than an hour and a half or 90 minutes, hypoglycemia, prolonged clotting times, or severe coagulopathies, especially at admission. Serum creatinine of being greater than 1.5 milligrams per deciliter after the first 24 hours, which shows with intervention this ongoing renal damage is occurring. Seizures or abnormal neurologic status, especially after normalization of body temperature. It's shown by Bouchama, probably obliterated that name, that 20% of humans have CNS abnormalities and unresolved brain damage afterwards with increased mortality. Other negative prognostic indicators include obesity, relative and absolute numbers of nucleated red blood cells, which we talked about. So Aroch found that greater than or equal to 18 nucleated red blood cells per 100 leukocytes at presentation had a 91% sensitivity and an 88% specificity for predicting death. And then last but not least, ventricular arrhythmias, continued hypotension without vasopressors, and refractory hypotension. In terms of prevention, or like what owners can take away from this, are make sure when you bring your animals outside, I don't care where you're at, that they have some kind of access to shade when they need it or when they want it, such as like a tent or a tree or something. And remember that the longer they're outside and the sun's kind of moving around, the day progresses, that the sun's moving, right? Which means shade's going to move. So check on them every hour. At the absolute least, if you feel like they have to be outside without you, because that shade that was there at 10 a.m. may not be there at 11 or 12 or 1, okay? Access to fresh water all the time, so make sure that they either have multiple sources of fresh, clean water or you're refilling them very frequently. The next thing you can do is refrain from exercise during the really hot times of the day. So like first thing in the morning or in the evening are probably best. Never, ever, ever, other than do not ever use ice in treatment, is that never leave dogs unattended in enclosed vehicles, especially during hot days. Sure, even with AC on, but I'd rather be safe than sorry and just take them with you. Acclimate dogs in new environments and warm temperatures, which again takes about 20 days for partial and about 60 days for full in some cases. And then kind of breezing through this, but management for upper airway obstruction. So if they have laryngeal paralysis or an upper airway mass or they're brachycephalic, just be more cognizant, okay? Some of the references I used would be like the Silverstein and Hopper Small Animal Critical Care Medicine book, and then the article called Heat-Stroke in Dogs in Today's Veterinary Practice in 2014 by Tabor. And yeah, so I know that was a lot. It was a really long video, but hopefully that was helpful for whoever. And if you have any questions, please feel free to reach out. Other than that, I really appreciate it. So thanks for tuning in. It was really great to have you here. I hope you found this interesting and you learned something, like never use ice in the treatment of this. um, if you like this video, please consider liking, commenting, and even subscribing or sharing. See you soon. You'll probably see me within the next week, assuming I don't have technical difficulties again. And I'll let you know how my second week was on ICU. And not sure what the next kind of teaching moment or lesson might be. So thanks a lot. Bye. Moist, everyone's favorite word.